All right, good morning, everyone. Thank you so much for joining our February Lunch and Learn. My name is Shelby McKeever. I work for the Health Council of Southeast Florida. I'm joined today by the lovely co-chairs of the FAC Home Visiting Work Group, Dr. Deborah Weiss and Dr. Wanda Rodriguez Bonham, and I'm going to go ahead and pass the baton to them for an introduction.
I want to welcome everybody, and then I'm going to turn it over to Dr. Wanda to introduce our illustrious speaker today. I just want to thank you all for coming. We're very excited about the presentation today. And if you have any questions, we may run over a little bit, but we are limited to 1 hour. You are welcome to email and also put your questions in the chat. So without further ado, I'll turn it over to Dr. Wanda to introduce our speaker.
Oh yeah, this is getting bad. This is getting bad. And the problem was, he was so unaware.
Wanda, you're on mute. Hi, Wanda. I think you might be on mute.
Oh, sorry. I'm talking away. As you can see, my lips moving. Sorry. I thought I had unmute myself. Dr. Joi Lucas is a board-certified pediatric pulmonologist at Nemours Children's Health. Currently, she serves as a chief of pediatric at Lakeland Regional Health and medical director of pediatric pulmonology at Nemours Children's Clinic in Lakeland, Florida. Dr. Lucas completed her residency in pediatric at Orlando Health, Arnold Palmer Hospital for Children, and fellowship in pulmonology at Children's National Hospital in Washington, D.C. In 2021, she published an Amazon best-selling book, Your Roadmap to Successful Asthma Treatment, A Parent's Guide to Preparing for your child's doctor's visits and long-term care. And without further ado, Dr. Lucas, thank you and take it away.
Thank you, Wanda, and thank you all so much for the invitation to speak. I'm really excited to be here today. Today's topic is pediatric asthma care in the post-pandemic era, and I'm going to go through the objectives. Let me just advance the slide here. The objectives of the talk are to understand health disparities in asthma care, review how the COVID-19 pandemic affected health disparities in asthma, review recent publications on post-pandemic asthma care in children and adults, and understand new health tools increasingly available after the COVID-19 pandemic that may be useful in closing health disparities. So let me tell you a little bit about myself. I'm a pediatric pulmonologist, but I'm also an asthmatic. And I was diagnosed with asthma at 5 by my mom, who's actually an allergist. So I had the best care from the very beginning. I grew up knowing I wanted to be a doctor, and specifically knowing I wanted to take care of kids who had asthma. So pulmonary was in my future. I attended residency at Arnold Palmer right here in Central Florida, and then went on to work for Nemours after I finished fellowship. So Nemours is in Central Florida as well, and I worked for them for 3 years before moving actually to the middle of the country, moving to Des Moines, Iowa. If you're not sure where Iowa is, it's right there in the middle. And Des Moines is the capital. I worked for a lovely children's hospital called Blank Children's Hospital, where I was able to participate in rural care. A lot of my patients were in agriculture, and I was able to see asthma from a rural standpoint and understand some of the challenges with caring for patients in a rural environment. So after my last winter in Iowa, where I had a multitude of -15, -20-degree days, I decided to move back to sunny Florida, which is where I came before the pandemic in mid-2019. So when you look at asthma in the United States, there's been a steep rise in cases of asthma and allergies in the US over the past few decades. From 2001 to 2011, the CDC estimates the number of Americans with asthma grew by 28%. And I'm going to show you a diagram here, which I think really kind of illustrates how asthma has grown in prevalence in the United States, you see that we weren't always the highest, but by 2019, the prevalence in the US was more than the UK, Australia, Germany, many other countries. So asthma affects people of all ages, but it most commonly starts in childhood. The greatest rise in asthma rates in the US was among Black children, with almost 50% of an increase from 2001 through 2009. And the question is why? There are no definitive explanations, but possible theories include the hygiene hypothesis, which suggests over sanitizing of a child's environment can lead to decreased disease resistance. The rise in allergy and asthma may be due to climate change, with triggers such as pollen becoming more prevalent, air pollution, and also the overuse of antibiotics. So GINA, the Global Initiative for Asthma, was established by the World Health Organization and the National Heart, Lung, and Blood Institute in 1993 to increase asthma awareness. And in their 2022 Global Initiative for Asthma updated report, they state asthma as a heterogeneous disease usually characterized by chronic airway inflammation. It is defined by the history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough that vary over time and in intensity, together with variable expiratory airflow limitations. Asthma is the most common chronic disease of childhood and affects over 6 million children in the US. Children from minority and low socioeconomic groups disproportionately are affected. And despite recent advances in pharmacological treatment and standardized management guidelines, asthma continues to cause significant morbidity in children. Respiratory viruses such as human rhinovirus, RSV, and influenza are common triggers for asthma exacerbations. And pediatric asthma is one of the leading causes of school absenteeism, with approximately 49% of school-age children missing school for 1 day or more because of asthma. So when you think about health disparities, you think about differences in outcomes. And when a health condition affects one group of people differently than another, that is what is defined as a health disparity. So health disparities exist based on factors such as race, ethnicity, age, sex, geography, disability, and citizenship. And vulnerable populations may include low-income individuals, women, children, older adults, and individuals in rural and tribal areas. As we move toward improving health disparities, we look at equality versus equity. So equality implies that each individual or group should receive the same resources, versus equity, which recognizes that each person has a different circumstance and allocates the exact resources and opportunities needed to reach an equal outcome. So when you look at health disparities in asthma, there are differences between rural and rural adolescent asthmatics. And youth living in rural areas, there's a lower prevalence of asthma, and they are more likely to have uncontrolled asthma and higher asthma morbidity than youth living in urban settings. And I certainly saw that in Iowa when I was practicing in some rural environments. When you look at race and ethnicity, Black, Hispanic, and Indigenous individuals in the US face the highest burden of asthma. Compared to white Americans, Black Americans are nearly 1.5 times more likely to have asthma. Puerto Ricans are nearly 2 times more likely to have asthma. Black Americans are 5 times more likely to visit the emergency department due to asthma and are 3 times more likely to die from asthma. And Black women have the highest rates of death due to asthma. When we look at why this happens and the root causes of asthma disparities, it is multifactorial. And not only does it involve race and ethnicity, but also structural determinants and social determinants of health, which combine with genes and biology and individual behaviors to create asthma outcomes. So as we grappled with rising prevalence of asthma in the United States in 2019, something else befell us, the pandemic. In December 2019, severe acute respiratory syndrome coronavirus 2, or SARS-CoV-2, was discovered in Wuhan, China. In January of 2020, the World Health Organization recognized a worldwide infection with the virus as a public health emergency, and they declared it a public health emergency as a pandemic on March 11th, 2020. The world shut down and countries sealed borders, sports teams canceled, seasons, schools closed, and employees were sent home. We all started wearing masks and social distancing. So when you look at how the pandemic affected people across the country, you see again that there were disparities in rural care. This figure shows the dynamics of the COVID-19 epidemic in urban and rural areas in the United States in 2021. And in general, rural areas in the United States face many challenges, including lower healthcare resources compared to urban communities. For example, over 4.7 million people live in 460 rural counties across the nation where there are no general medical or surgical hospital beds. In addition, 16.4 million people live in rural areas with no medical or surgical intensive care units. Rural residents have a shorter life expectancy than urban residents, and rural households also report a lower median income. The results of this study, published in 2021, revealed that the COVID-19 landscape in the US was dynamic with substantial changes over time and space. And although results at the national level indicated greater COVID-19 incidence rates in urban compared to rural counties in the Northeast and Mid-Atlantic regions of the US at the beginning of the pandemic, the intensity of the pandemic shifted to a rapid surge in rural areas, with particularly high incidence located in the Midwest of the country. And you can see in the third period, there was actually a greater incidence in the middle of the country than on the coasts. So there was a magnification of health disparities during the COVID-19 pandemic for people of underrepresented minority groups. And this has been well studied and documented. And there were many factors. There were general socioeconomic factors, like increased multidimensional poverty. Many people were essential workers, so they were in the groups that were first exposed to COVID. Other families that were in minority groups did not have the opportunities to socially distance because they were living in multi-generational households. There were personal factors like genetic determinants, and also healthcare factors. People in these groups were more likely to have lost insurance coverage, problems paying for medication and healthcare, and closure of primary care services. So as we look at these health disparities that we're facing, some of these minority groups, we recognize as healthcare providers for children that these are the parents of our children. So if the parents are having all of these issues, then the children, by sheer fact that they're in these households too, are suffering disproportionately. So as of February 2023, globally, there have been over 750 million confirmed cases of COVID-19 and over 6.8 million deaths. And the pandemic has dramatically changed the way we live, work, socialize, learn, and take care of the sick. In the US, despite having vast resources, there have been over 1 million deaths from COVID-19 and over 100 million cases, the largest number of any country in the world. So as we look at asthma and COVID-19 and the early concerns, initially the Centers for Disease Control and Prevention, or CDC, listed asthma as a significant comorbidity for COVID-19. But there were a lot of questions, especially in caring for kids. It was uncertain how the SARS-CoV-2 virus would affect kids with asthma. Early evidence suggested certain groups had more severe disease with COVID-19, including those with asthma. There were concerns that there was an increased risk for contracting COVID-19 if you had asthma, higher morbidity for COVID-19. And we didn't know if asthmatics would have greater healthcare use at a time when the healthcare system was going to be very stressed. And then lastly, we worried if our patients would have worsened asthma control during the pandemic. Telemedicine rocketed up in numbers, and we as providers were very quickly transitioned to doing telemedicine mostly at home for safety of our patients, but also safety of us as providers. And as a doctor who had primarily been in the clinic with the traditional model for examining a patient, putting your hands on the patient, talking to them, getting to know the family in the office, this was a little jarring. But I think the lesson that I learned during the pandemic was to pivot and to be very flexible and to understand that there are many ways that you can communicate and educate your patients. When I did telemedicine, I had a glimpse into the households of my patients. I oftentimes was doing a visit with a child that was very allergic to cats, and they were showing me their lovely Mr. People's cat that I didn't know they had, or I saw a grandparent smoking in the background and I didn't know there were smokers in the household. So it was really a glimpse into their everyday lives, and I got to understand some of the environmental risks that these patients would maybe have more exposure to when they were at home, learning from home, working from home. However, I also was able to learn about some of those social determinants of health that I've mentioned. People talked about the fact that they lost their job. They weren't sure how they were going to put food on the table. There was a lot of food insecurity. And so I began to understand that I needed to relate to my patients on many different levels. And so during 2020, I decided to become more active on social media. I actually created a brand called Asthma Kid Care Go Bag and Dr. Joi MD. I started to live stream on Facebook and on Instagram and to take people's questions because people were really craving accurate information from a trusted source. I created Asthma Kid Care Go Bag, which is the bag you see here, to keep kids with asthma organized and ready to treat asthma symptoms when they happen. I also wrote a book called Your Roadmap to Successful Asthma Treatment, a parent's guide to preparing for your child's doctor visits and long-term care. And the response was overwhelming. And I think people were really excited to have information that they could rely upon, because I was really surprised by how many people were getting their information from TikTok or Facebook and it wasn't accurate. So when we look at early pandemic barriers to asthma treatment, one of the things we saw in pulmonary was the suspension of spirometry. So spirometry is a pulmonary function test, and it allows us to objectively evaluate lung function. And it's one of the mainstays of diagnosing asthma in patients, usually 5 and up. Because it was an aerosol generating procedure, we were not able to do spirometry in the office. So we rapidly switched to virtual visits, and this was recommended for lower acuity children, and in-person visits for children with recent asthma exacerbations were actually recommended. However, it was hard to get people to come to the office. They were terrified of contracting COVID on their way to our office. And one of the things we experienced in pulmonary and pediatric pulmonary was little guidance on a return back to school for children with asthma. People who had to work in person needed to know if their child was safe to go back to school. And so as a pulmonologist, we had to create our own ways to gauge, is this child okay? Is that one not? And give advice to our patients. And looking at asthma treatment during the pandemic, there were multiple international guidelines that supported continuous use of maintenance controller medications, including inhaled corticosteroids, anti-leukotrienes, and biologic medications, except when acutely ill with COVID-19. Biologics are medications that are used to treat severe asthma, and they're injectable medications. Use of metered dose inhalers with valved holding chambers or dry powdered inhalers were preferred over nebulizers, because nebulizers, again, were an aerosol generating procedure that was thought to spread COVID. We were recommending to our patients that they have an updated asthma action plan. We reviewed with them medication adherence and also technique, as well as aeroallergen avoidance measures. So as we look at the early pandemic findings, and this was published in Pediatric Pulmonology in 2020, this article highlighted that with COVID, children seem to be less symptomatic with COVID-19 than adults. But among children who were hospitalized with COVID-19, 1/3 required PICU admission. So those kids were pretty severely ill. They do an overview of racial and ethnic disparities and morbidity with Hispanic and non-Hispanic Black children having higher cumulative rates of COVID-19 associated hospitalizations than white children. And they looked at the scarcity of data as well on children with asthma. And this was one of the first articles published in Pediatric Pulmonology in 2020. So it was really an eye-opening overview of what people were seeing across the country. In this article, they look at the impact of social determinants of health on COVID-19 morbidity and mortality. And the authors suggest the impact of adverse social determinants and COVID-19 outcomes are likely amplified in children with asthma. And there's an interplay between race, ethnicity, and asthma outcomes that may be further compounded during the COVID-19 pandemic. And so they highlighted some of the things that I've mentioned: crowded living spaces, lack of access to care, racial and ethnic disparities, as well as unintended consequences of school closures, including food insecurity, which may lead to malnutrition, poor physical and mental health, and a risk of lowered immune response to COVID if our patients did contract it. This early pediatric pulmonology article in 2020 did postulate that paradoxically, asthma may be protective. So the SARS-CoV-2 virus is a beta coronavirus and a single strand positive sense RNA virus that uses the ACE2 receptor to attach to the respiratory epithelial cells. And this ACE2 receptor may be underexpressed in the lungs of atopic children. So in reading that early in the pandemic, that was very surprising to me, that actually kids with asthma may do better because they didn't have the way for the COVID-19 virus to enter the respiratory epithelium. This early journal article also said that initial concerns about children and young people with asthma not being particularly affected by COVID was a consideration, that COVID maybe didn't cause as much morbidity in our asthmatic patients as we thought. And that too was pretty groundbreaking. Later findings for articles looking at pediatric asthma during the COVID-19 pandemic really supported what was published earlier. This article published in 2022, November of 2022, showed that acute exacerbations were less common among the first year of the COVID-19 pandemic compared with years prior. Children who sought care were of higher acuity. There were higher ratios of hospitalizations and PICU admissions compared to ED visits, and typical seasonal variations in asthma were not seen. And this article also gave an explanation for why people with asthma and children with asthma maybe were not as sick as we would have thought. And the reasons are multifactorial. There were fewer viral infections because people were social distancing, wearing masks. There was improved hand hygiene. There was less physical activity, and physical activity is known to be a major trigger for asthma symptoms in young children. There was less air pollution as we were all working from home and socially distancing, fewer school exposures, and then improved adherence to medications. So this article, published in 2022, investigated clinical characteristics of children hospitalized with asthma exacerbation during the pandemic as compared with those hospitalized during the same months in the year prior. It was conducted at Children's National Hospital in Washington, D.C., where I did fellowship, and it found that there were reduced hospitalizations during 2020 as compared to 2019. However, a higher proportion of children hospitalized during the pandemic required magnesium sulfate in the ED, suggesting that children presented with more severe exacerbations compared to the pre-pandemic year. They also found that the patients hospitalized for asthma during the COVID-19 pandemic were older and had less atopy, including eczema and food allergy, than those hospitalized pre-pandemic. So this article supported everything else that we had seen. GINA came out in 2022 with official guidance about COVID-19 and asthma, and this confirmed that, we were seeing in asthmatics something unusual, something that we had not expected. To the question of, are people with asthma at increased risk of COVID-19 or severe COVID-19? People with asthma do not appear to be at increased risk of acquiring COVID-19, and systemic reviews have not shown an increased risk of severe COVID-19 with well-controlled mild to moderate asthma. GINA comments that overall studies to date indicate that people with well-controlled asthma are not at increased risk of COVID-19 related death. However, the risk of COVID-19 death was increased for those who recently needed oral steroids. They recommended continuation of maintenance medications, and they also said that in 2020 to 2021, many countries saw a decrease in asthma exacerbations and influenza-related illness. So the early journal article in Pediatric Pulmonology really held true, and the subsequent articles that have been published also mirror that. So in 2022, GINA came out with new guidelines for severe asthma, and these guidelines included use of biologics. One of, I think, the silver linings of the pandemic is that biologics were authorized a little bit faster, probably, than we would have seen in a non-pandemic year. And also, many of these drugs were authorized for use in kids. So you see several are greater than 6 years of age and greater than 12 here. And then home use, the auto injectors were authorized for many of our patients. So if you were a severe asthmatic and you were coming to our office to receive these medications, these biologics, every 2 weeks, every 4 weeks, you could stay at home and be treated. I wanted to just briefly go through, just show you the complex pathophysiology of asthma. I'm not going to go through all of this, but this shows that asthma really comes in two types. Type 2 high asthma, which is eosinophilic asthma, and this is what's most common in children, and type 2 low asthma. Type 2 high asthma is really caused when you have pollutants, viruses, and bacteria which irritate the respiratory epithelium, and you have the production of cytokines such as thymic stromal lymphoprotein and interleukin 33 and interleukin 25 that then proceed down a cascade of inflammatory mediators. So tezepelumab is one of the biologics that was most recently approved in the last 2 years. This is the newest drug in a long list of biologics. It works in a novel way. It's an anti-TSLP. We had not seen that before. It works high up in the inflammatory cascade. It does not require biological markers for authorization, and it's approved in kids 12 and up. It does not have a home indication just yet, but that hopefully is coming soon. So again, biologics for a pediatric pulmonologist, or for those of us that treat severe asthma, I think were the silver lining of the pandemic. So I wanted to segue to caregiver experiences because I think this is really important. The perceptions of many of the parents that I've spoken to are very different than the data that we just reviewed. This was an article published in Clinical Pediatrics in 2022, and it was a survey of caregivers whose children were involved in 2 randomized trials of telemedicine enhanced care for uncontrolled persistent asthma in Rochester, New York. So the authors hypothesized when they embarked on this study that the COVID-19 recommendations to stay at home would affect asthma symptoms due to children's prolonged exposure to home asthma triggers, including but not limited to tobacco smoke, mold, dust, and other indoor environmental allergens. And they suspected that caregivers would report additional home life stressors and experience difficulties obtaining care or asthma medications for their children due to the pandemic, and that these factors would cause changes in home management of their children. The average age of the participating children was 7.5, 84% of the participants were Black or Hispanic, 56% were male, and 73% of caregivers had at least a high school education. When looking at the caregiver experiences with COVID-19 study, the objectives again were to examine the influence of COVID-19 pandemic on families and children with persistent asthma, looking at the pandemic-related stressors. And the caregiver worries that they found were primarily manifested in restriction of activity. So 80% were worried about COVID-19 and their child's health. Greater than 50% restricted their child's physical activity to avoid asthma symptoms. And there was a dose-dependent relationship between increase in caregiver worry about COVID-19 and new restrictions on physical activity, financial hardship, difficulty obtaining asthma medications, and nocturnal asthma symptoms. And so these findings raise concerns that children with persistent asthma may be at particularly high risk for weight gain and obesity associated with asthma morbidity during the pandemic because of their parents' concerns about them contracting COVID-19. So also in this study, 1/3 of the caregivers had additional financial hardships due to the pandemic, and 24% reported they or a family member had lost their job. So this study showed that most caregivers of children with asthma remained persistently concerned that the pandemic would negatively affect their child's asthma, despite reassuring data that did not support asthma as an increased risk factor for severe COVID-19 infection. And I found the study to be helpful because that's what I was seeing in my population. Parents remained very concerned about COVID-19, despite sharing with them the data that we've reviewed. When you look at adolescent concerns about COVID-19 and asthma, this was a study that was recently published in February of 2023, and it examined adolescents' views regarding how the pandemic impacted asthma severity and self-management. They looked at differences based upon urbanicity, sex, and race, and ethnicity. And the adolescents reported if they believed their asthma severity remained the same, improved, or worsened during the pandemic, and if it changed, how it changed. And also they reported if they had modified their asthma management. And they looked at this for kids who were primarily in a rural setting, but also the majority of the kids were in a rural setting, but also in an urban environment. So looking at the data from this study, most of the patients reported their asthma severity remained unchanged. Females had a higher relative risk than males of reporting that their asthma worsened, and urban youth had greater odds of reporting they changed their asthma self-management compared with rural peers. They do acknowledge that in this study, the urban youth lived in counties where there was anywhere from a 30 to 60 time higher COVID-19 reporting rate. So the urban youth were perhaps modifying their asthma self-management as a result of increased risk in their environment. And when they talked about how these kids modified their use of medications, they were more adherent to their medications, they were more cued into their symptoms, and they were looking at the information that was provided by their provider. And so that to me was really telling, because it shows that the kids are listening. And so if we are making the effort to educate them, they are listening, they want information, and they will utilize it. So telemedicine and asthma care, I think this, the use of telemedicine is probably by far the greatest change in care that we have seen coming out of the pandemic for asthma. Usually with telemedicine, we were doing it as an adjunct, or, because of proximity, a patient really couldn't travel, they had surgery, the parent couldn't come to the office. We weren't doing it out of necessity. But, during the pandemic, we were doing telemedicine because there was no other way to care for our patients. And so a report by the Centers for Medicaid, by the Centers for Medicaid and Medicare found that between March and mid-October, more than 24.5 million of 63 million eligible patients, nearly 40% received telemedicine services covered by Medicare. There were definitely challenges with rolling out telemedicine because this was not evidence-based, and this was not because we were doing this because of patient satisfaction, but really because it was out of necessity. I think most care providers in the practice where I worked were able to pivot. They were able to find a way to comfortably see their patients. And moving forward, hopefully we will be able to use a hybrid of telemedicine and asthma care. When you look at the different types of telemedicine options that are available to optimize asthma care, there are synchronous and asynchronous types of telemedicine. So synchronous is going to be a live model. The provider is in their office or at home or in a clinic. The patient is in their school or at home, and you are communicating at the same time, offering advice, assessing the patient. You can also do a facilitated visit where the patient goes to a center where there's a telepresenter. And so they often will have a digital stethoscope or be able to take blood pressure or complete an asthma questionnaire that then can be used by the provider during their visit. So face-to-face telehealth is probably the most popular post-pandemic, but depending on what resources are available in your clinic or office, both of these are able to be provided to the patient and very cost effective. So when we look at asynchronous forms of telehealth, mobile health with use of app trackers has become very popular. Nemours, where I work, has an asthma diary, and patients report that they find it very helpful to be able to record their symptoms from day to day to understand how they're doing. Remote patient monitoring is also something that was increasingly used during the pandemic, and e-consults. There is a digital divide, and earlier studies in telemedicine showed that people with lower socioeconomic status had more difficulty making connections for virtual care. Some of the challenges with telemedicine that we experienced is that patients and providers may not be tech savvy or don't have great internet skills. There was a lack of internet access and bandwidth for some of our patients. And some of the things that some of the smaller practices and health systems encounter was the issue with technical staff, technical support staff. If you had an issue with your visit, how did you resolve it? Practices also needed to invest in proper infrastructure and training of providers and patients to perform the visit seamlessly. So this study was published in 2022 and looked at the adult transition to virtual asthma care. And the objective of the study was to assess changes from in-person to virtual care during the pandemic in patients with persistent asthma compared with the same period before the pandemic. So this was completed at Kaiser Permanente among members aged 18 to 99 years with persistent asthma evaluated during 2 periods, March to October 2019 and March to October 2020. And they did a comparison of asthma exacerbations with hospitalizations, ED visits, and use of oral corticosteroids. And also they reviewed asthma medication metrics. And you can see in this figure here that between 2019 and 2020, there was a marked increase in virtual visits for these Kaiser patients. So this study found that those requiring medical financial hardship assistance were less likely to be in the no care group or to not seek care, and more likely to have sought care in person. That there was no evidence for an adverse impact on the important clinical outcomes of hospitalizations, ED visits, and courses of prednisolone for asthma flares, or on medication adherence. And that virtual care was adopted across age, race, income, and insurance groups. So use of virtual care tended to be lower in older patients, those with a lower household income, mental health diagnosis, or higher number of comorbidities. When you look at telemedicine in pediatrics, this was published in 2021, and it reviewed outcomes in children with asthma for telemedicine interventions, both school and clinic-based. And it examined emerging technologies such as smartphone applications, web-based services for adherence, and virtual presence devices. And so they acknowledged that there were not many outcome-based or many studies that showed outcome. That when they looked at school-based interventions and a meta-analysis, the meta-analysis suggested school-based self-management interventions reduced hospitalizations by 0.16 admissions per child over 12 months. And there was a decrease in the proportion of emergency department visits over 12 months. There was a reduction in unplanned hospital or primary care visits for the school-based interventions. And so the outcomes for school-based interventions could be verified and were statistically significant. For synchronous telemedicine, there was limited data. And unfortunately, the data that they did have did not definitively show an improvement in outcome. Asynchronous telemedicine visits, such as web-based trackers, there was a significant decrease in wheeze episodes and decrease in visits to offices of doctors. However, what this study did put forth is that we need additional studies to understand how telemedicine in pediatrics can be utilized in the future, and if outcomes actually are improved with the various methods of telemedicine that are available. So what are the benefits of telemedicine? Increased access to healthcare is one of them. If you're in a rural area and there are no subspecialists near you, you can access them through telemedicine. Oftentimes, telemedicine is cost neutral, if not more cost effective. With telemedicine, we were able to eventually use spirometry because there are ways now to remotely assess lung function and use that data to diagnose asthma much as we would if you were in the office. Some of the pitfalls are confidentiality. During the public health emergency, platforms did not have to be HIPAA compliant. And so there was a cyber risk for patients giving their information that might be seen or heard by somebody not within the health system. Access still remains an issue because not all families have equality of access to technology, such as the internet, broadband, Wi-Fi data, or devices. And some may have additional issues such as learning disabilities, auditory or visual needs. English not being a first language for some patients can be problematic if health systems had not contracted with interpreters that were available via telemedicine. So safeguarding, that simply refers to when you're in an office visit, you can pick up on cues from a child. Are they nervous? How are they interacting with the adult who's brought them to the visit? So with telemedicine, it may be more difficult to discern if there's something going on with the patient that needs to be addressed. Quality of consultation. you still can't examine the patient with telemedicine as we traditionally would. And so as a care provider, I was always very nervous as a pulmonologist, not being able to physically listen to the lungs and making an assessment and ordering medications, that maybe I had missed something. There are, of course, options for digital stethoscopes and otoscopes, but I never felt very comfortable that that was going to be better than my exam in the office in person. And then there are financial pitfalls of telemedicine. There's a high financial cost with development of telemedicine and practices, and then parity and reimbursement when you're looking at billing became a concern as the government pulled back from the medical emergencies. Some health systems and insurances were not reimbursing for the visits. So despite clear asthma guidelines, there is still a high percentage of asthma morbidity, and poor adherence to asthma medications is reported in 49% to 71% of pediatric patients. Over the last several years, digital health has emerged as a promising research area for achieving optimized personal asthma management. And this review article in 2021 explored digital health interventions for pediatric asthma and the most relevant issues affecting their implementation. So there are many different digital health interventions, serious games. These are not games that are for fun, but they are to educate. Hopefully kids do find them fun. There are several that were on the market earlier, that were using older gaming systems that also came back with the pandemic. Bronchi's Asthma Adventure, Asthma Files, Wee Willy Wheezy, are free games that are available on the market. And these games are focused on improving children's knowledge, but in looking at the evaluation of outcomes, none of the games have shown that they actually improve outcomes. But knowledge certainly, is something that patients will gain from using the games. So electronic monitoring devices have become increasingly more popular. Smart inhalers are something that are on the market, and these measure time and date of drug actuations. They are fitted, they come in many different forms, and they fit on your inhaler, and they basically have a microchip that objectively detects and stores the data and shows each time your patient uses the medication. And that's great because sometimes, with some of the earlier smart inhalers, patients would just kind of waste their doses before they came in the office visit with you. But with the updated technology, you can see when the patient used the medication to know that they've been using it consistently. And some of the newer versions are actually Bluetooth enabled, so you can download the data in real time and see when your patient's actually using the medications. So tools for self-monitoring of symptoms have become more popular. The asthma symptom tracker, my hospital, Nemours, has. And Nemours has been very forward-looking and innovative in their approach even before the pandemic. And so many of the patients that I have use the asthma symptom tracker, as I mentioned. Also medication reminders on your phone are helpful. During the pandemic, there were a number of asthma apps that were developed. There are over 500. These have not been well studied or tested. And there's also a high risk of loss of private information with some of the apps. So as we look to future goals of digital health interventions in pediatric asthma, we're trying to hit the bullseye. We're looking for that intervention that allows us to educate, to allow the patient to understand the disease process, allows patients to self-manage, that also shows them the importance of adherence and control, prevention of adverse outcomes, and also communicates with them easily. So as I look back over the pandemic and asthma care, the silver linings, the things that I think we'll move forward with are that telemedicine and emerging technologies have the potential to improve future healthcare delivery to children and young people with asthma. And the pandemic brought many terrible things, but also in asthma care, we were able to get biologics. I think we were better able to understand the needs of our patients because we recognize that there were disparities in healthcare, and now we can move forward working and advocating for our patients so they do better in the future. So, is this the end of the pandemic? I like this slide because it shows kind of where we've been and maybe where we're going. We're still not sure, but hopefully the lessons that we've learned thus far will help us to better care for our patients with pediatric asthma in the future. Thank you so much for listening. And if you have any questions, I'd be happy to answer them at this time.
I had a question, Dr. Lucas.
Sure.
Thank you. That was a fabulous presentation. I loved your asthma kid care go bag. That's fabulous. I found in my own research that the adolescents are the most challenging age. Did you have any specific strategies for reaching out to adolescents during this last very difficult period during the pandemic?
Yes. And, you know, I really make an effort with adolescents to ask, what is your day like? You know, I ask them from sunup to sundown, what are you doing? I ask them about their friends, and I think if you make an effort to understand kind of in their world, in context, what the challenges are that they're having, it helps you to tailor their asthma care. And I understand that there are standard guidelines for asthma care, but if it's a choice between a child either using or not using a medication, I will give them a clear plan that says, okay, you're not taking your Symbicort, you're not taking your Advair. What can we do? Can you do it once a day? Can you do it at a certain time? Can we use a reminder? So I think if you're engaging with the patient and just making sure that you're personalizing their care delivery within the confines of the guidelines, I've had better outcomes with adolescents doing that.
That's great. They are a challenging age group to deal with, for sure.
They are. I love them though, because they can tell me how they're feeling. So it's easy in that respect. And, I think once you kind of break through their outer shell, they're enjoyable to work with. So they're one of my favorite patient ages.
I agree. I got into college teaching from my work with at-risk teens, and then I was offered a job at the college level. So I agree with you. They're our future, and we have to make sure we reach out to them and keep them healthy. So thank you so much. That was wonderful.
Again, thank you so much for this presentation, Dr. Lucas. Folks, we do have additional time for questions. So if you want to either unmute and ask Dr. Lucas some questions, or you can drop them in the chat as well, and we can go from there.
I have a question, Dr. Lucas, and again, thank you so much. That was awesome. I know that you posted on one of the studies or several studies that said that when asthmatic kids went to, and also I think it's also for adults, went into the hospital, they basically bypassed everything and they just went from the emergency department straight to ICU, PICU. Do we know what were the possible causes of this?
Yes, so that is one of the things the study at Children's National Hospital in DC talked about that. And a lot of the families were just very reluctant to seek care. They knew their child was worsening, but they were terrified of going to the hospital and contracting COVID-19. So there was some hesitancy there. There was also a concern that medication adherence perhaps wasn't as good for those patients that we saw very sick, requiring the magnesium sulfate being admitted to the ICU. So although, medication adherence was better for some patients, not for all. And so those are the kids that we think came into the hospital. And then you look at environmental exposures. Overall, yes, people with asthma did well, but if you happen to be in a household where there was heavy smoking and you couldn't really get out because of the social distancing, then those were the kids that were going to be higher risk for coming in with issues. So I think although the broad overview and the over and underlying causes of why we saw decreased asthma symptoms have been explained, there are still pockets where that does not hold true.
Okay, I think it also will be nice to, we know about the medication adherence that most people did over the pandemic time, especially the first year and few months.
Mm-hmm.
But I will also like to see a study from the pharmacists. You see, how many people actually undusted their uncontrolled medication prescription and start using them in order to, to get control of asthma. Because at the beginning, yes, If you're like us, we were asthmatic, it was like, okay, you have a high incidence of that. I also saw a study about the use of leukotrienes, anti-leukotrienes, like the Montelukast, that actually protected some of the asthmatics that they were using. Can you abund more on that?
Yeah. So, interestingly, I think if you were a child who was atopic, there were decreased risks for severity of COVID-19. And, going back to the angiotensin receptor, the ACE2 receptor, there was downregulation in people who were known to be atopic. And so I think it's complex and it has not been fully elucidated. But the overall trend was if you were a kid who was allergic or an adult and you were on your medications, the risks were not super high for you to have a severe COVID exacerbation. So I think use of anti-leukotrienes as well as inhaled corticosteroids is all kind of in the same group of controlling asthma. And leukotrienes, of course, work through a different pathway than steroids, but they all are used, those medications are used for people who are atopic.
Thank you.
And please note that one CHES credit will be available for today's presentation, and I'll go ahead and drop that link in the chat.
Dr. Lucas, I was very interested. I want to read more about the protective factors of asthma in reducing susceptibility to COVID-19. My own father died of COVID-19, and I've been perhaps more careful than many as far as my mask use and hygiene. I'm wondering if any studies are going on now, since we seem to have more and more variations of COVID, to find out if these protective factors can be replicated for non-asthmatics.
Yeah, that's
a
really interesting studies. Yeah, I don't know of any studies offhand. And that's a double-edged sword because you don't want to give somebody asthma and allergies to protect against the possibility of COVID. But I mean, it's a good thought. It's a good thought. And I think as we look for, additional ways to treat people who have COVID, those are things that, may be considered. But no, I have not seen any studies specifically that speak to that.
It's interesting. It's counterintuitive. One would think that asthma would predispose someone because you already have lung sensitivities. My other question, and this could be to you or anybody that wants to answer it, I love statistics, and I find it somewhat perplexing that the US has the highest rates in the world when India and China have 1 billion plus people. Do you think that it's partly underreporting in other countries? Do you think that our care is at fault? It might be a combination of factors, but it's kind of appalling to see that the US, with all its wealth and resources, had such a high morbidity rate. What is your take on that?
Yeah, and again, I think it's multifactorial, and I don't think that the greatest asthma minds in the world can explain it fully. You're right. I think some other countries are probably underreporting, but you also have to keep in mind that looking at the UK, at Australia, at other countries that are very similar to ours in terms of population in some respects, they still have less asthma prevalence than we do. So there's something different here. I think it goes beyond an environment and it's perhaps how we are medicating our children. Are we using antibiotics more? Do we have more exposures to pollution? Is there more allergy and asthma here because of environmental concerns? All of those you have to look at. But I don't know that there's any one explanation for why we are so high.
Yeah, it's disturbing, especially since we certainly have many pockets of poverty in this country. It's sad, but when you look at a country like India with such huge areas of poverty and that they are below us, that we are more extreme, you have to wonder what is going on. I wish that somebody could pinpoint it. I believe that, it's like, I'm not a diagnostician, but if you have to address a problem, you have to know, first of all, what causes it, right? You can just treat the symptoms, but it's nice to know the underlying cause, and I'm sure it's multifactorial, but it's been very disturbing, both during COVID, the morbidity rate, and the asthma morbidity rate. It's quite disturbing in my view, anyway.
Well, you bring up a good point because, we saw a rebound in viral illnesses after the pandemic. And it kind of speaks to the hygiene hypothesis where you sanitize and you clean everything in an effort to keep the child healthy. And then they go out into the world after all that hand sanitizer and they get RSV and viral enterovirus. And 2 years later, they're in the hospital. So you do the best you can. And I think in this country, we do have a lot of resources, which are wonderful, but maybe some of those resources are predisposing us to developing more allergic pathways instead of, being in more rural environments that you may have in other countries where there's not as much asthma. There are other illnesses and disease processes, but not as much asthma.
That's a very good point. I mean, we used to go out and play in the grass, the mud, whatever, we weren't told, wash your hands every 5 minutes. It's true. Maybe
Yep.
we've gotten over concerned with that,
Yes.
Too much of a good thing.
I have a goddaughter that was born during the pandemic, and she did not feel a blade of grass. She had not been outside until she was, I think, 7 months old. And I think ordinarily, you would have taken your child to the park and exposed them to some things, but with the pandemic, she had been exclusively an indoor baby. And so that was a little shocking to me. But I think there are many parents who have kids that, hadn't been to the grocery store or out in the world because of the pandemic.
Doctor, pardon me if I butcher your last name, Dr. Nahas, you made a comment. Would you like to explain a little bit more about that?
Sure. I really believe our diet is a key factor in our health, and I'm not the only one to think that. If our children are living on Takis and chips and whatnot, and not really eating fruits and vegetables and good protein and good fats, their bodies are not going to build the proper way. They're going to have junky cells, like their junky food, and your immune system's going to suffer, and you're going to just do worse in all areas of your body, not just your lungs, obviously. But that's one strong theory I'm seeing over and over in my clinic. That is a big contributing factor to disease in our children.
Yes, thank you, Dr. Nahas. And also, Katie also pointed that untreated sleep disorders breathing might be an underlying reason for COVID disparities, asthma, deviated nasal septum, tongue tie, mouth breathing. Yeah, we have that. And I also read a study that at the beginning of the pandemic, so many people did not have that they had a lung condition, or they were like underdiagnosed. And that's one of the reasons it just started killing people because of lung failure, respiratory failure. But it was mostly because underdiagnosed lung conditions on either adults and children. So there's so many things that definitely, when this virus hit us, it was totally new and we had no idea. And so it just so many factors. But we have a couple of minutes, and I will like to thank Dr. Lucas and everybody for joining us on our not monthly, but our Lunch and Learn webinars. And I just want to give you a little previews of the next one, which will be on March 22nd, and it will be by our Dr. Nina Ramirez. And the title is Asthma and the Importance of Implementing the Air Cue in Practice. So we will send you information about that. And again, Dr. Lucas, so happy that you were able to join us and do this marvelous presentation. And we're looking forward for more.
Well, thank you so much for having me.
Yes, thank you, Dr. Lucas. And I couldn't agree more about diet. There have been some articles recently in the literature showing an association between asthma outcome and diet. And I do believe we have quite an awful diet in this country. I agree with you. I teach nutrition, among other things. So we're finding out more and more about ways we can improve our health and our medical outcomes through diet, as well as doctors like Dr. Lucas. But we have to do our part in taking care of ourselves, right? So thank you.
Again, thank you, everybody. Thank you for your time, and hopefully we'll see each other next month on the 22nd. Have a great day, everyone.
Thank you. Thank you, Shelby. Thank you, everyone.
Thanks. Bye-bye.
Thank you. Have a wonderful day.